cases?
Yes,
Yours are
sir.
given as short case, isn't it?
Yes, sir. Short cases.
What is your first
Sir,
case?
72 years. So shall I start, sir?
Ah,
Yes. A 72 years old male came with complaints of swelling in the right inguinal region for the past 4 years, which is gradual in onset, progressive in nature, aggravated by coughing and relieved by lying down. Uh, Patient having complaints of pain in the right inguinal region,
if it
no
is
history
given
of
as a
chest.
short case, Muthumani, you can
Yes,
just
sir.
straight away go for the diagnosis and proceed. Okay? This is a case of right inguinal, reducible inguinal hernia, isn't it?
Yes, sir.
It is not irreducible hernia, it
Okay.
is a reducible inguinal hernia. What other problem
Yes,
is
sir.
there in the patient?
In past history, patient is a known case of coronary artery disease for which he was operated. So CABG done before 15 years. Patient is on medication now. Tablet aspirin once 75 mg OD. Tablet clopidogrel 75 mg OD. Tablet atorvastatin 40 mg HS. And tablet metallar 25 mg BD. Sir. No other known comorbidities. In personal history, patient not a known case of smoker. And in family history, patient history of similar illness in the family. Patient had a attack of patient had a coronary artery disease and he expired with that. Sir.
Which patient? Relative.
Patient's father's, sorry.
Father. We must say family history and patient expired means I can so quick way. Okay, we will not
So,
worry about all that thing. Now,
diagnosis
what?
is 72 years old male, uh, known case of coronary artery disease, status post CABG, now planned with diagnosed as right reducible inguinal hernia, planned for open inguinal mastoplasty.
Very good. Okay. So, what are any other details you require about the CABG? You said
So
it
number
is
of
done
grafts.
15 years ago. Number of
Yes, sir.
grafts, number of blocks.
So totally 3 grafts have been replaced.
Okay, so 3 blocks are there. Here's the 3 grafts done. How many were arterial grafts? How many were venous grafts?
So 2 venous grafts, 1 arterial graft, sir.
One arterial. Why this information is important? What is supposed to be the life of an arterial graft and the life of a venous graft? After which they can also go in for obstruction and blockage.
I don't know.
Okay. Anybody? Arterial graft is supposed to be much better because of the wall thickness, which is supposed to last about 10 to 12 years. Whereas venous graft life is supposed to be 8 to 10 years. After that, it is there's a possibility that the graft itself can become occluded. Okay? So that information is very, very important. Sometimes if they don't have a good internal memory or radial artery, they put all venous grafts for all the blocks. Then the life of that block will be much more lesser. So, but luckily this patient has had the surgery for 15 years and still going strong. Okay, right. So, what other important questions that you would like to or information get from this patient apart from this CABG?
Whether
There
patient
is
is
a
having any
possibility that we
complaints
can
of.
get an anginal pain now after 15 years.
Yes, sir.
Yes, we can develop, isn't it?
Yes, sir.
So,
Yes, sir.
you must ask him whether he is getting any anginal pain. Okay. Supposing he says no anginal pain, I'm quite comfortable. What other information you want from this patient?
Any, sir, history of shortness of breath, sir.
Effort tolerance. Okay. Next
Yes,
question is effort tolerance because his
yes.
myocardium has been revascularized. We must know how it is able to withstand any effort. So his effort tolerance or METs is the next important thing. So first to rule out any subsequent anginal pain. Second, always ask for effort tolerance. So how do you, the common question they may ask you is what is METs?
One metabolic equivalent is the oxygen consumption of 3.5 ml per kg per minute in sitting position, sir.
Anything else to be added to this answer? Weight of the patient. Average weight of the patient of 70 kg. Okay, so this 3.5 ml per kg per minute is an average oxygen consumption for a 70 kg adult when he is at rest, not in when they are doing severe exercise. So, how many minimum METs a person should have? Is it enough if you have one MET?
I am unable to hear. Unable to hear you.
How many METs the patient should have? Minimum.
4 meds, sir.
4 METs minimum, right? Very good. What is the objective method of calculating the metabolic equivalent? What is the laboratory method of estimating the patient's oxygen consumption?
CPET.
Cardiopulmonary exercise testing. No, don't use the abbreviations in the examination. CPEXT should not be the answer. You should say cardiopulmonary exercise testing. What is the important parameter you try to get by doing this test?
VO2 max.
VO2 max 1, very good. Then what other thing you will get? Huh? What threshold you get?
Anaerobic threshold.
Huh?
Anaerobic threshold.
Anaerobic threshold. Okay, the level below which the tissues will go in for anaerobic metabolism. So anaerobic threshold. What is the value? Normal value for anaerobic threshold? 11 ml, okay, per minute. Okay, below that it will be when you are exercising, the tissues will start going in for anaerobic metabolism, which will result in lactic acidosis. Okay, so this is the other common question they may get asked you. One is 4 METs is a minimum that you should have. There is the cardiopulmonary exercise testing. So these are all the information that you want. Now this patient is on aspirin, clopidogrel, statin, and beta blocker. What are all the drugs that you want to stop before surgery? Which are all the drugs you would like to continue before surgery?
Sir, I would like to continue tablet metalar, sir, and tablet atorvastatin, sir, and tablet
Okay.
aspirin, sir.
Aspirin, very good. So these 3
I will
drugs can
stop
be
tablet clopidogrel, sir.
clopidogrel. Okay, so right. Now, what is your plan of anesthesia for this patient?
So subarachnoid blockage.
Final single subarachnoid block with a long acting or a short acting drug. You know, say the drug, the volume, everything. Just saying
Okay, sir.
subarachnoid block. So this patient, how much?
3 ml of 0.5% hyperbaric bupivacaine, along with 60 mg of buprenorphine.
60 mg of buprenorphine. Why do you choose buprenorphine? What are the advantages and disadvantages?
So faster onset and it will prolong the analgesic effect, sir.
It will extend to the post-operative period also as a pain relief.
Yes,
Okay. What are the disadvantages?
So nausea, vomiting, side effects such as nausea, vomiting, it may
Okay.
cause respiratory depressions.
Okay. Anything on the table? A mild discomfort. Pruritus, itching. Okay. Patient may have pruritus nose as well as body. Okay. That is one of the major disadvantages. How can you prevent that pruritus? If you plan to use buprenorphine along with the local anesthetic. Can you give any drug as a pre-medication to prevent this pruritus produced by buprenorphine? Antihistamine. We have to give Benadryl, diphenhydramine hydrochloride. That is the pharmacological name for that. You can give 25 to 50 milligrams of Benadryl or diphenhydramine hydrochloride as a oral tablet. It is available as a gelatinous capsule that can be given 1 hour prior to your planned anesthesia, and you can add this. What are the things that you have to take care if you are planning for a, but before that, how will you just like that plan uh, final, or you have to evaluate the patient? Always you must say you will evaluate and then only plan your anesthesia, isn't it? So what
Yes,
evaluation you want to do?
I will proceed with investigations first, sir.
Okay, what are the routine
Routine
investigations
hemogram and-
that you do for any surgery, right? Very good.
Yes, sir.
What is the special investigation you want to do?
So along with ECG, I will do echo to assess LV function and any newer regional wall motion abnormalities, sir.
Very good. Okay. Can you find the working status of the grafts that have been placed in this patient? Can you find out whether they have this
By
regional wall
coronary
motion
angiography, sir.
abnormality is an indirect method of assessing the blood supply. But is there any method to find whether the blood flow to the graft through the grafts are normal or not? Any investigation that will help in doing that, finding out?
Pharmacological stress testing.
Huh?
Pharmacological stress testing.
Pharmacological stress is showing again. It will not quantify the blood flow. No? It will just show whether the myocardium is going in for any ischemia or not. But
Coronary
CTG.
angiography.
CTG.
not
CTG.
non-invasive
Angiogram.
thallium testing, so nuclear studies. Okay, that will show exact blood flow and the supply to the area. Okay, so that question, if they ask you whether there is any easy method of finding out the blood flow, the thallium scanning is a very easy method, but costly, of course, expensive, but that will show the clear flow of blood through the grafts and the area that is supplied. So even small areas of ischemia not perfused will be easily seen by doing a thallium scan. Okay, right. So your choice will be, supposing patient refuses spinal. He says, some of my friends have advised me not to go for spinal because they say long term we get a backache and all that. So he refuses to have a spinal. Then how do you manage? What are the
Can
other
do it under
options?
epidural.
No, he says I don't want any injection in the back. Patient is
External blocks, sir.
he has Googled and he has got a good knowledge and he says nothing to do with my back. You cannot go to my back at all. That is the patient's condition. What is your other option?
Radio inguinal nerve blocks, sir.
Okay.
Ultrasound guide.
Ultrasound guided. Okay.
General
So have you
anesthesia.
ever done that? You ever done a inguinal nerve block?
Seen once.
Seen one. Okay. So that is only ilioinguinal nerve block will be sufficient, or
So
have to give
hypogastric nerve
what is
ones.
called the hernia block? What is the difference between a hernia block and an ilioinguinal block? Hernia block, you have to give injection in 3 places. One is to block the ilioinguinal nerve at the closer to the anterior superior iliac spine. Second thing is a vertical block from the tubercle to the umbilicus to prevent the crossover fibers from the opposite side. And third is the infiltration into the line of incision along the inguinal canal. Okay, if you do all the 3, then it is called an inguinal hernia block. Whereas if you do only an ilioinguinal block, sometimes the midline fibers crossing from the other sides may cause a little bit of discomfort or pain. So that may not be. What is the current name for blocking the same ilioinguinal nerves? The block that you use in the modern day, It was earlier called Inguinal nerve block, given at the closer to the anterior superior iliac spine, medial 1 centimeter and inferior to anterior superior iliac spine to infiltrate and go between the internal oblique and the transversalis to block these nerves. What is the current block which is employing the same technique to block these two nerves? The older version of ilioinguinal block is called by a new name nowadays, which you give in the petit triangle or small triangle. It is called tab block. Transverse abdominal plane block is nothing but blocking the same ilioinguinal nerves, L1 and L2. Okay, that is the root value. Right. Patient says, I don't want to be awake. You can't give me any local injection or anything. He wants only general anesthesia. Then how do you manage this case? You're hearing
So
me?
he could also say about GA with Activa or supraglottic airway devices.
That's what I'm aiming to ask him. That's why I'm asking questions to find out whether he is confident about VA. Muthumani, are you hearing me or not?
Yes, sir. Some signal issues. Sir. I
You
can
are not
hear you, sir.
hearing me. Are you
Yes, I
hearing
can
me
hear
now?
you now. Yes, sir. Yes, sir. I'm hearing you. Yes, sir. I can.
So supposing patient wants only general anesthesia, how do you, what are your method of giving GA for this patient?
Yes, sir. GA with the endotracheal intubation, ET tube we can use, and supraglottic airway devices also we can use.
Yeah, so you can give GA by IV induction followed by paralysis and tracheal intubation or just insertion of LMA. You want to leave the patient in spontaneous breathing or paralyze and controlled ventilation.
Spontaneous breathing.
Spontaneous also you can leave. The relaxation will be adequate or inadequate. Do you require relaxation for hernia surgery? Some surgeons are very fussy. They want full relaxation.
Okay, sir.
Because you can do conventional paralysis and relaxation can be achieved through that also with both supraglottic airway and endotracheal intubation. How do you monitor intraoperative ischemia?
Sir, with ECG, transesophageal echocardiography,
Okay.
and
Now from ECG, how will you detect ischemia, intraoperative ischemia? Because for a hernia, if you
sir,
ask
we
for
can.
transesophageal echocardiogram, that is too much. But with simple
Yes,
ECG, how will you detect ischemia? What is the special placement of electrode you would like to do to detect
sir, lead
ischemia?
V5, sir.
Huh?
Lead V5, sir.
Lead V5 or CMV5 configuration. Have you heard of CMV5 configuration?
No, sir.
Yes, sir.
How to do that CMV5, which is supposed to detect left ventricular ischemia much more sharply than lead 5. Where do you place the electrodes for CMV5
Oh,
configuration?
right arm electrode over the suprasternal notch and left arm electrode on the V3 position.
So it's a regular left arm will be on the apex, and the left leg will be at the left shoulder. So three positions. One is the right arm shoulder electrode will be posted on the central manubrium. That is why it is called CMV5. Central manubrium. That is suprasternal notch. Then you put the left arm electrode over the apex of the heart, and you put the left leg electrode on the left shoulder. If you place like this, then it is called CMV5 configuration, and this is supposed to be much more sensitive in picking up left ventricular ischemia compared to the lead 5 electrode. Okay, so that is how you detect. Supposing there is a change, ST elevation or depression, and you detect ischemia, what will you do intraoperatively? A known coronary artery disease patient. How do you detect intraoperative myocardial infarction?
So ST depression or ST elevation or T wave changes, sir.
Yeah, I have told you that. So you find that and you suspect that, then what will you do? You detect or suspect intraoperative MI or ischemia, how to proceed and manage the patient.
So avoid increase in heart rate, sir.
Very good. Then
By using
100%
NTG,
oxygen.
sir, for coronary vasodilatation.
NTG. Then
And adequate pain relief should be given, sir.
excellent, very good. Then you convert to 100%
Maintain
oxygen.
adequate depth of anesthesia.
Operatively, patient will wake up, isn't it?
Sir,
Somebody said 100% oxygen. I think it's Vinita, isn't it? Vinita, did you say 100%
Yes, sir.
oxygen? So intraoperatively, if you give 100% oxygen, patient will regain consciousness. That will prevent this problem, isn't it?
Yes, sir.
So how to manage that? What he says is right. Control the heart rate, control the pain, and maintain the diastolic blood pressure. That is very, very important. Okay, so you should not cause any diastolic hypotension. And of course, immediately you will not have a elevation of the troponin, but send for trop as early as possible to confirm your diagnosis. Okay, and the other thing is you have to anticoagulate the patient. Depending on hernia surgery, is not a major bleeder or anything. It can be the surface procedure, so the intraoperative blood loss can be easily controlled. So you can start the patient on heparin also to maintain the blood circulation without any thrombus formation. Okay, so these are all the things that you have to remember with that. And just show presentation on